This is the fifth presentation of brain neoplasms prepared by Prof. Sharaf and revised by Prof. Rami Edward. It will be concerned with intracranial schwannomas. Here we can see that there is a left fifth nerve schwannoma extending into the Meckel's cave, this one, fifth nerve, trigeminal. Here we have a small right third nerve schwannoma, small one. Here we have small homogeneously enhancing glossopharyngeal schwannoma. This one is a dumbbell-shaped tumor, homogeneously or about to be homogeneously enhancing, crossing the petrous bone, and this is the site for the facial nerve to pass within its canal, resulting in a dumbbell-shaped tumor, and sometimes it could be seen at this region. This is a facial nerve schwannoma. At its site of origin from the geniculate ganglia, there is a small right facial nerve schwannoma. This is the one. It's not in line with the vestibular schwannoma we know about. It's something perpendicular, course of facial nerve, and here it appears like a homogeneous spot, homogeneous mass, homogeneously enhancing mass. A vestibular schwannoma is a benign primary tumor of the myelin forming cells of the vestibular nerve, which is its nerve, as overproduction of Schwann cells. The tumor then presses on the hearing and balance nerves in the inner ear. Schwann cells are cells that wrap around and support nerve fibers. Here you can see the tumor, widening of the internal canal, with the facial nerve and cochlear nerve itself are seen together. So this is a tumor of the myelin sheath wrapping around the vestibular nerve, Acoustic neuroma is also called vestibular schwannoma. It is neither acoustic, it's not involving the hearing nerve. It's neither acoustic nor neuroma. It's not of nerve cell of the nerve cell itself. It is a schwannoma from the cells around the nerve. So it is coming from vestibular nerve, and it's coming from the vestibular nerve sheath, the Schwann cells, and it is not coming from the acoustic nerve and or nerve cells. So although we use these two terms alternatively sometimes, but the correct name is vestibular schwannoma, and you know now that it is vestibular, not cochlear. It is schwannoma and not neuroma. Here the widened right internal auditory canal compared to this side. Beforehand we were doing the posterior anterior film, and we tried to get the petrous bone inside the orbit, the conventional X-ray, and we can check the canal on either side. If there is any difference of more than 3 millimeter, it is considered pathological. So the CT makes it easy for us. This is the internal auditory canal and meatus, and this is the left canal and meatus, and apparently this one is wider than this one. It's occupied by an intermediate intensity in T2 and markedly intensely enhancing tumor in T1, which is vestibular schwannoma on the right side. Right vestibular schwannoma arising at the right internal auditory canal, causing widening and funneling of the canal. This is left vestibular, where we have part of the tumor inside the canal and part of the tumor outside the canal. So it can have two extensions, not only within the canal but also protruding out, and this resulted in what we call ice cream cone. Left vestibular schwannoma involving the canal and the meatus and bulging out into the extra-axial space. Here is the confined vestibular schwannoma to the internal canal only. See, the canal here is widened inside, but the meatus is normal compared to this one. This wide internal canal is due to this enhancing tumor, which is seen in a transverse pattern, homogeneously enhancing, indicating intracanalicular vestibular schwannoma. This is the typical appearance of the ice cream cone extending into the canal, but main bulk is outside the canal. It is a giant, and being giant, areas of breaking down, areas of devascularization or less vascularization are there. So we get the giant usually with inhomogeneous enhancement. This one has a left vestibular schwannoma but presents with hemorrhage. This is hemorrhage as seen in CT, compressing the left wing of the fourth ventricle. And here the process is different. The canal is spared and the big tumor is based on the petrous bone, and the petrous bone in this area is eroded compared to this one, and at the same time you have the dural tail on either side. Dural tail still homogeneously enhancing. The main bulk of the tumor is seen as intermediate T2 and markedly enhancing T1 with T1 weighted images. There is some displacement of the brainstem to the other side with obliteration of the nearby extra-axial space or CSF space. This is typical of meningioma of the petrous bone. Meningioma of the left petrous bone with dural tail. Here we have vestibular schwannoma on both sides. This is one of them, and this is the other one, and it extends out here and there. The main bulks of the tumor are inside, but extends outside. It's bilateral in a case of neurofibromatosis. Bilateral again. This is a big one on the right, and this is the ice cone with the ball, ice ball, and here is a small one causing widening of the canal and starts to bulge outside the internal auditory canal. Bilateral schwannoma in neurofibromatosis. Here we have combined, as we said before, those occurring in longitudinal pattern, crossing the petrous bone, or confined to the adjacent area of the temporal lobe here at extra-axial position, are due to facial nerve, while these ice cones are bilateral, widening of the internal auditory canal on both sides, and bulge into the extra-axial space. In case of neurofibroma, it's combined bilateral, acoustic, and facial nerve schwannomas. Strangely enough, that vestibular schwannoma can also occur as cystic and marked displacement of the brainstem. And here we have another one, small intracanalicular. So small intracanalicular and large, both extra and intracanalicular tumor with cystic changes, neurofibromatosis. Now come to the epidermoid. This is something different that behaves as a cyst. This cyst is hypo in T1 with contrast, hyper in T2, and presented restricted diffusion in diffusion-related images. This is Epidermoid. It's non-enhancing, usually presents as hypo T1, hyper T2 with restricted effusion. Another epidermoid which is not enhancing. This is CT with contrast. It presents lobulation. So cysts with lobulations, cysts with restricted diffusion, and cysts with no evidence of enhancement are usually epidermoid. Now dermoid means fat, and here we have a large dermoid cyst which is seen as hypodense T1, and at the same time it is enhancing. The dermoid can enhance because solid tumor. And in this one there is fat suppression. Compare these two. There is fat suppression here, and the tumor is suppressed due to the fat content. So fat containing tumors with heterogeneous enhancement and usually extra-axial are due to dermoids. What is this? This is a tumor which is seen in CT as dense calcific, while in the MRI T1 weighted image there is a tumor and hypointense area due to calcification, but the tumor is inside there, resting on the dura, resting on the petrous bone, is not related to the canal on either side, or so it is mainly extracanalicular, it's mainly extra-axial, it is calcific, it has a dural base, and this tumor is showing a small dural tail here It is a calcific left CB angle meningioma. Thank you. This is the effect of radiation on vestibular schwannomas. It becomes less vascular and only the margin is still seen with the contrast, but the central part is hypo-intense and is not homogeneously enhancing this effect of radiation. Thank you.